Welcome everybody, we'll make a start. My name's Robyn Whitaker and I'm Director of the Wesley Centre, and in a moment I'll introduce our two guests for today. I want to start with a question. I wonder what stereotype comes into your mind when you hear the words drug addict. The media would have you believe it's a tough-looking young person, possibly violent, and maybe stealing your stuff. But addiction is more complicated than that. The addicts I've met, both when I worked as a minister in a congregation and in my friendship circles, tend to be highly qualified professionals who are either addicted to prescription drugs or alcohol. But our society tends to treat these different groups of people quite differently. Which leads me to wonder if there is any real moral distinction between drinking wine, smoking a joint, or having a bump of cocaine. Why is one legal and the others not? And if addiction is a health issue, is it ethical to imprison people who are addicted to substances if they have not committed other crimes? And how do we balance the needs of the individual to the commitment to keeping wider society safe? These are some of the questions we'll hope to unpack in the next hour, and there's obviously a lot we can say about this topic. But let me introduce to you, firstly, Dr Dan Fleming, who is National Director of Ethics for St Vincent's, Australia's largest not-for-profit health and aged care organisation. Dan is an adjunct professor in the School of Medicine at the University of Notre Dame, or Notre Dame as we say in Australia, sorry, Americanism. An adjunct professor in the Faculty of Health Sciences at the Australian Catholic University. He holds a PhD in theological ethics and is widely published in the areas of moral philosophy, theological ethics, and moral education. At St Vincent's, he collaborates with clinical teams and services who provide care for individuals who use drugs, including those subjected to the criminal justice system. Adrian Webber works at Uniting VicTas, who have offices in the building next door, where he holds the position of General Manager, Alcohol and Other Drugs, Mental Health, Carer Services in Victoria and Tasmania. That's a big portfolio as well. Prior to Uniting, Adrian has worked in the community services sector, in alcohol and drug services, and in the tertiary education sector as lecturer in counselling, mental health and addictions. He also co-chairs Uniting's Drug Law Reform Working Group. So welcome to you both, and it's wonderful to have you here giving your time. I wonder if you might like to just introduce yourselves to people by telling us how you got into this topic and where your work relates to it.
Sure, I'll go first. Thank you. So I have worked in the AOD sector for around 16 or 17 years, both in New South Wales and Victoria. I've worked for Uniting for almost 7 years now, mainly in our AOD or drug and alcohol treatment services. And Uniting has provided services to almost 7,000 AOD consumers in the past 12 months alone. I'm really interested in this topic and mainly because of also our involvement with the criminal justice system and the consumers that we work with, including our work with the Port Phillip prison. And I believe that people with AOD-related concerns are some of our most stigmatised and marginalised people in our community. And I'll stop there and maybe...
So, as per your introduction, I'm a theologian and an ethicist, and I work in the nation's largest social enterprise, St Vincent's. And there are kind of two parts to this answer. One is a me story and how I do ethics, the others is the St Vincent story. So the me side of it, ethics is sometimes reduced down to decisions about this or that choice we might make in a particular situation. But I like to think about it in the terms that the great 20th century philosopher Iris Murdoch gave us, which is that ethics is about one's choices, but also more fundamentally about what we see. It's what we see, our vision. And the Protestant theologian Stanley Hauerwas said, ethics is a learning and a struggle in how to see. We inhabit a moral imagination. The way we see the world really matters. And the things that I add to their work is that it also matters our vision is related to where we're standing and who we're standing with. And there's a strong dimension of Christian theology, which we can get into later, which invites us to stand in particular places and see the world from there. When you stand near suffering, Cornel West, probably the greatest living philosopher, says that the condition of truth is to allow suffering to speak. When you stand near suffering, you see the world differently. And a big part of the ethics that I do is to try and come close to suffering, wherever it is, and invite questions about what truth, beauty, and goodness look like. These are the ethical questions that come to mind. And I do it in St Vincent's, which has this extraordinary legacy, founded by 5 women who came to Australia from Ireland in 1838, and got to work straight away, standing with people who are suffering. Women in prison was their first ministry, and seeking out ways that they could respond. And their legacy gave birth to a lot of beautiful ministries in this country. And particularly in the context of our discussion today, care for people who use substances. Just up the road was the first academic centre for the study of alcohol use at St Vincent's in Melbourne. Famously, in the late 1980s, we had the first needle exchange service in the country up in Darlinghurst. It was an act of civil disobedience. It was illegal at the time. And that was set up by a doctor called Alex Wodak with the support of the Sisters in St Vincent's. And then some of you would know the story of the supervised injecting room in Sydney, where the Sisters of Charity famously said yes to that, offering that service. It was later blocked by Rome, another story we could get into later. But there is this legacy of standing close to suffering and responding to it. So the first day that I arrived at St Vincent's, 8.5 years ago, the first thing that was put on my desk was, can we look at the supervised injecting room again? So there's a personal ethical story here and an institutional story that's brought me into this space.
Yeah, wonderful, and we'll pick up on lots of these threads. And of course, this church, and even has a long history, and even a quite recent one, of a number of ministers, including the minister in this congregation, who's sitting just there, speaking out in favour of safe injecting rooms, which have not gone forward with the Vic government. But let's do a bit of background. Adrian, this might be a question for you, but feel free to jump in, Dan. What are some of the reasons you see for people using drugs? Tell us a little bit about the patterns and what drug addiction and the kind of dynamics of that actually look like.
I think there's a whole spectrum of why people use illicit drugs. I mean, we really go from the experimental to the recreational end of using illicit drugs, also using non-illicit drugs, so alcohol, tobacco, to the extreme end, to the other end, which is based around loneliness and trauma and significant complex traumas. There's a whole range of reasons why people use drugs and become addicted or dependent on a range of drugs.
Do you want to add?
Only that I get to spend a lot of time with our clinicians and lived experience workers in this space. And let me tell a little brief story. It's a one-sentence story, which tends to show up in this kind of space. A young man suffers from anxiety and discovers that using a small amount of cannabis helps with his anxiety. And invariably, this is often how the story of drug use starts. Sometimes it's recreational, as you said, Adrian, but very often it's dealing with an underlying kind of issue. Now, would you believe that this guy, 6 months later, has a criminal record? He can't go into the profession he's studying for at university. His family's ostracized him. And guess what? There's a whole lot more anxiety attached to that, which leads to more drug use. And by the time our people see him, there is a lot more going on and a lot more that needs to be dealt with than that initial question back there. And that's true if you spend a night in our emergency department or you go up to our ICU. The people who are in there because of some issue related to substance use, very often the story starts with that. It might be anxiety, it might be trauma, it might be some other suffering, but there is often a reason under it. And that's the first thing our addiction medicine clinicians taught me when I came to St Vincent's. Don't look at the substance, look at what's underneath it. And it's only when addressing what's underneath it that we can actually understand what healing might look like, especially for someone who's got a dependence.
Which captures really well the difference between treating this as a legal issue and treating this as a personal, seeing the person. There are a lot of stigmas around drug use and legality. So there's a couple of questions here I'd love us to just unpack a bit. I asked a class on ethics, this is last year, we were actually discussing abortion, and I asked them about the morality of abortion, and one of the responses I got very quickly was, well, it's legal, so what's the issue? And I think with drug use, we get the opposite, which is certain substances are illegal, so therefore they're immoral or unethical, etc. Help us tease apart the problems of treating this in a legal framework. And we've already touched a little on some of the implications for that for people, and the kind of stigmas that go with that, and we'll get to harm minimisation. But how do the legal and the moral interact, and how could they perhaps interact better? Whoever wants.
So legality play an important role in shaping our views about certain drugs and how we respond as a society. So illegality also obscures our thinking about the people who use illicit drugs. So it allows us to demonise particular groups of people and our ability and willingness to keep them safe and from harm. So we know that prohibition, which has really been the prevailing model globally for the past 60 odd years, hasn't worked. It hasn't worked to reduce harm or to make people safer or healthier. In fact, it's thought to keep people safe from harm and given many people who need help. People fear coming for help because of the legalisation or coming into contact with the criminal justice system. So the criminalisation of drugs also causes a disproportionate harm to already marginalised communities such as First Nations people, both locally and globally.
Yeah, I think perhaps to build on that, and I've already given you an example of an act of civil disobedience, so you might guess at where I'll land on this. But for me, I'm an ethicist, I'm not a lawyer, and the ethics question, not only the bias of my profession, but I think in general, ought to come before the question of law. I think sometimes law, this is true in healthcare ethics more generally where I work, but particularly true in this space. Sometimes we use law as a heuristic, as a cognitive shortcut for questions of ethics. If it's legal, it's good. If it's illegal, it's bad. Now, sometimes that might be perfectly true, but it's worth digging into it a little bit more, because it's not always the case that what's legal and what's good closely align with each other, and similarly, the Needle Exchange Service, I think, is an example of this. So I'd want to dig under it a little bit more, and I think just in that context, and you would have more information on this than me, but it's relevant that most of the people who land in our emergency department related to substance use are there with legal substances. Not with illegal substances. So the kind of health burden created in this country through substance use is actually through substances which are perfectly legal and in fact kind of encouraged in our culture. And that's true of alcohol. And then there's also the use of prescription medicines and so on. So I think that there's a real difference there. We can get into how to think ethically about substance use in a minute, but I do think that the cognitive shortcut creates a problem.
Huge problem, yeah. And let's lean into that, and this is a genuine, I don't have an answer to this question. Are there some substances that in and of themselves we would want to say are unethical? And is that even a framework to talk about a substance? So we're trying to shift away from saying that person is unethical, the stigmatising of an individual, which the legal system does. But are there substances that are so deeply harmful we would want to say there's a kind of immorality or unethical aspect to that substance? Or are we really looking at substances, if I use the example of alcohol, where you might say, and as a Christian, Jesus seemed to like wine. There's Protestants who've tried to make cases that what Jesus was talking about was not actual wine, but wine can be a social cohesive, it can be joyful, there's lots of things that can be good about it. It can also obviously be hugely destructive. So, is that even the right ethical question to ask, ethicist Dan?
Do you want a short answer or a long answer? Or I'll try and give you a thick answer without going on for too long. But first, I might just say something very briefly about stigma, because we touched on that a little bit. And sometimes this is offered as a kind of, it's good to stigmatise certain things because they are inherently dangerous for us. And stigma, and this is more your domain than mine, the Greek word actually goes back to a connotation of branding someone, firebranding someone, or tattooing a criminal. So you were branded for life. And I mean, you would know this, Adrian, but the people who I know with lived experience professionally and personally say that kind of stigma is the biggest barrier for them accessing help reaching out for help, because it's like you walk into an emergency department, you got a tattoo on your head, and people recoil from you immediately, or you try and reach out to family or friends, people recoil from you. So I don't think stigma is the answer in relation to any substance whatsoever, because it creates a deficit for people who would need help being able to get help, and it places the problem in the wrong spot. In terms of thinking ethically about the use of substances, here I'm an Aristotelian, informed by Aquinas and some others as well. Aristotle, I think that this is a correction to the libertarian approaches to drug use that sometimes float around in public, but Aristotle held the view that the central feature of human life was excellence or flourishing. We ought to orientate ourselves towards flourishing. But he had a thick concept of flourishing, which was living in community with other people, living in such a way that I was able to achieve moral excellence. And he suggested that there were 4 central virtues, character dispositions, that ought to be part of that for the human person. They are moderation, courage, practical wisdom, and justice, so a concern for others as well. So some of these are self-referential, some of these are about others. Now, Aristotle's a little boring, so I would add some things like creativity and fun and, dare I say it, in a church, love. These are all virtues that are worth celebrating. So I would think about a substance first with that moral vision in the background. What does this psychoactive substance do to me as an individual in terms of my capacities to be courageous, to act with due moderation, to act justly, commit to the good of others, to love, to be creative. And the reality is that some substances really help with that in moderation. They do. And I think that's how I would think about individual substances. But there is also, so I think there are just 2 little brackets that I'll put here. One is that this opens up kind of a twofold distinction. One is that it recognizes that there is an agent-relative character, or there's something agent-relative about the way in which substances interact with me as an individual human person. For example, I know people for whom the tiniest amount of cannabis is extremely dangerous because it sets off psychoses and so on. Agent-relative character, moderation means something different for that person than someone who can tolerate more. The second is that it goes to your question earlier, Robyn. There are some substances which are so intrinsically dangerous to my personhood that I can't see a case for saying, yeah, a little bit of that's okay. And crystal meth is probably a good example of that. That's different to thinking of someone who has a dependency on substances. That's not a moral judgment about their decision making, but it's a way of thinking about the illicitness. The final thing I would say, and then I'll be quiet, is that this also opens up an interesting way of thinking about the context in which substances are used, which opens up some surprising possibilities. So at St Vincent's, we ran in 2023 a trial using psilocybin, which is the hallucinogenic compound found in magic mushrooms, to help people with anxiety as they neared the end of their lives. And it was enormously effective. In a therapeutic context with a lot of deliberation around it, this actually helped to kind of short-circuit the brain in a certain sense and enable people to step into that space with flourishing. There's an Australian story on it from 2023 if anyone's interested. So I do think context matters in this space as well.
Yeah, thank you. Adrian, do you want to add to that from your experience working in this space? You know, both the stigmatisation and this idea of moderation, is there any small amount? I feel like some of the prevailing sort of therapeutic responses still are the AA, NA kind of, which do enormous good. There have been criticisms of those programs as well. But in your experience, how do you see these issues?
Yeah, look, I guess I echo Dan's sentiments that it's unhelpful to stigmatise any particular substance. It's really and criminalising drug use stigmatises people. And I'll tell a very brief story of this is actually before I worked in AOD, which is one of the reasons that I ended up going to work in the AOD sector, was that I was working in employment services actually, and I was working alongside a young man who I'll call John, who I was assisting him to find work. He had been unemployed for a considerable period of time, experienced quite significant social anxiety, had been coming in over a period of time looking for work, and I found what I thought was the perfect job for John. And I called him and said, John, come in, I've got a great job, let's sit together and we'll talk it through, go through the application process together. John came in for the appointment, we went through the role, and then he sat back, he said, I can't apply for this job, I can't go for this job. And I said, oh, but this is perfect for you. Why is that? And he said, well, what I haven't told you, because I have so much shame, is that not only am I unemployed because I have severe social anxiety, but I'm unemployed because I also have a gambling addiction and I have an addiction to cannabis. And I've been too afraid to talk about it. I've been afraid I'll get arrested if I talk about my cannabis use, so it's holding me back. So if I take this job, and he said what I do is that I go every fortnight when I get my Centrelink payment, I go at 12:01, I pull out all my money, I buy enough canned food to last me for the fortnight, and then I spend the rest of it on gambling and cannabis. And I've been so afraid to tell you this. If I take this job, I'll have more money, I'll have a bigger problem then to deal with, and I don't want to deal with that. So for me, that was just that, and that was the reason that I ended up moving across to work in AOD, because I thought the complexities and the care that was needed for somebody, and the stigma and shame that we continue to propel in the sector through criminalisation was really profound for me.
Yeah, thank you. And that's a profound story of someone who's actually trying to build their own, right?
Absolutely.
Systems of moderation. Let's see where we might go next. So we've touched on prohibition, which is has dominated, I think, drug response, at least for the last, quite significant amount of time. I did a bit of digging around in preparation for this and found that in 1887 in London you could buy cannabis cigarettes, and these were promoted by pharmaceutical companies as helpful for coughs and sleeplessness. And of course, famously, it's a little bit dubious, but Coca-Cola once had cocaine, or at the very least the coca leaves that can produce cocaine. So we as a society do have a mixed history, but the 19th century was probably dominated by a move towards prohibition. Some of that came very strongly from Christian circles and motivated by, in the best iteration of it, a real concern that substances were causing family breakdown, they were driving people into poverty, particularly in an era where men earned the money, and if they spent all that money on alcohol, entire families were being left destitute. And so this was sort of seen as a social and moral element. But let's talk about prohibition versus harm minimisation. It might help to start by saying what's a harm minimisation approach for people. I think probably a lot of people here know what that is, but let's just be clear about it. And then I want to talk about, what's the downside of it? Why doesn't prohibition work? But let's talk about harm minimisation first. What is that?
So harm minimisation is a framework that recognises that people will use substances, and if we are to provide support, education and assistance around using safely, then people's lives will be better overall. In a nutshell, people will be safer and they're more likely to seek the support that they need as opposed to prohibition.
I just heard a terrific way into this from Alex Wodak, who I interviewed earlier this year as part of a St Vincent's initiative. And he always talked about a conversion story to harm minimisation. It was very interesting. And he told this story of being down at the Alfred Hospital when one of the new towers was being built in the 1970s. And he asked the architect about how they planned for how many beds they would need in certain wards. And the architect said, well, we've actually over-planned. We are going to need less beds in the facial injury part of this ward because seatbelts have become compulsory. And Alex said at that moment he was a convert to harm minimisation because he could see how an intervention which protected people in the context of an activity that could be dangerous could actually change the way literally the structure of a health system works. So those beds became available for others. So I think that's one way into this as well. We actually use harm reduction, harm minimisation techniques all of the time, and it's simply applying that framework in the context of substance use.
So in the context of substance use, what does that look like? We've referred to safe injecting rooms. It was in the Age just this week that the Brotherhood of St Lawrence will be hosting in Fitzroy the first free pill testing facility, and there'll also be mobile units going out to festivals over summer. Can you give us some examples of what the best practice of harm minimisation looks like and the kind of systems around that?
I think you've just named it. I think some of those examples are perfect best practice examples of harm minimisation.
I mean, there are things like overdose awareness campaigns, provision of naloxone for people who overdose in lots of different contexts. There are all sorts of different examples, and they just fit within a broader framework of. I was trying to think of an analogy for this as I was travelling down here on the tram. One which kind of offers a rationale for this that doesn't get stuck in the stigmatisation and the legal questions. And I'll try this on, you can tell me if it works or not. But so I have a 4-year-old and we live near a creek. Now, we talk about water safety a lot. She does swimming lessons. And sometimes I see kids playing down there at the creek. Sometimes they go in the water. I really worry about what's going to happen to them because the water's dirty. But there are also some really dangerous parts of the creek. Now, when my little 4-year-old is old enough to be playing down there, my sincere hope is that she knows what harm can endure from going in the water. My second hope is that if she lands in there for one reason or another, she's got the skills to be able to get herself out safely. My third hope is that if she can't for some reason, she knows how to call for help and calls loudly, unashamedly. This is the opposite of stigmatized help. And 4, that people will come running to help. And I think that actually sets up a framework for thinking about these kind of interventions, which places them not in a reactionary or a consequentialist sense, but actually in a framework of loving concern for each other. If we really love each other, if we genuinely have a concern for the dignity of each other, what does it mean to create kind of an ecosystem where if I do land in trouble, if I do end up in the creek of dependence and the water's rushing over me, I don't feel like I can't, your story, I can't even name this problem and reach out for help. So the rationale for it is just as important as the definition of it, I think, because that then leads to a whole lot of other solutions. Seen on its own, it's one thing, but when you put it in an ecosystem, it can be a much better communal kind of response.
And thank you. So if we work with that analogy, and I don't think that works, what part, you named 4 things there, what parts of those are we doing well in a harm minimisation approach? So if we use the example of a safe injecting room or something, you're creating a place for someone who's in the substance, but some safety networks around it. What else needs to happen in those places, or what does happen in those places that is doing the when you need help, the last stages of those? Because I think there can be a naive assumption that this is just a place to go shoot up, right? And it is that, and we shouldn't say just, because that can actually save a life. But what else is part of that package in a full harm minimisation approach?
I think that's a really tricky question. I think within, so if we use the injecting room as a specific example, so the injecting room has safely managed over 10,000 overdoses. Has provided more than 170 health and social support services within during its time since it's been open. It provides bloodborne virus testing, screening, education, referrals into dental, housing, AOD treatment. So they're not simply a place where people can go and use safely, but they're a place where they can get connected into the services, those whole of life services that are absolutely essential, and connecting people back in. Also reducing that stigma when somebody is in that service. It's a safe place for someone to be. They then make connections outside in the community to be able to live more safely and with less stigma as well. So I think these are really great models within. I think that some of the, and maybe you'll get to this, some of the limitations around some of these harm minimisation approaches is the kind of the surroundings, such as the media, et cetera, and the kind of the attitudes that people have to going into. And we know that the injecting centres is one of the most stigmatised services within Victoria or nationally, because of kind of lots of the hype around it. But actually, there's some really amazing work that goes on inside. Yeah.
Yeah. And perhaps if they were a bit more normalised and we didn't just, we've only got one, right, in Victoria, in Richmond. Yeah, if it was more normative, then maybe some of that stigma about actually going in would reduce. If we do the flip, the devil's advocate thing, what are the limitations of a harm minimisation approach, or what are some of the criticisms that come through? So one I hear, and I don't know if there's any actual data base to this, is that around Richmond there is a higher rate of petty crime now, or home invasions associated, you know, that there's a fear that brings users to the area and that crime will go up. I don't know if you have any research to counteract that or support that, but what are the kind of arguments against this kind of approach for the community? And it's really a question about how we're weighing up keeping safe users with wider societal needs, I guess.
Yeah, sure. I actually recommend reading the report that was done on the medically supervised injecting room in 2023, because it addresses a number of these issues and it has a whole lot of data in it. And the chair of that committee is in the audience, but I'm not going to embarrass that person right now. So it's a very rigorous look at all of those kinds of questions. Maybe if I can answer the ethical train in your question, which is what is a good argument against this approach. I think that when it's taken at a thin account of what harm minimisation is, and sometimes I think proponents fall into this trap, healthcare practitioners and others, we give a thin account of what this is about, and it tends to show up either in libertarian terms. People are free adults, they should be able to do whatever they want, and we should just make sure that they're as safe as possible when they do it. Or consequentialist terms, there are particular outcomes, saving lives, and all of this is very important, of course. But I think those two thin accounts are subject to critique precisely because they don't deal with the deeper issues at play here, which is, why do people get caught up in using such strong psychoactive substances? How does that turn into a dependency, and what do we owe them in terms of a response? And actually sitting behind in the kind of the year 2000, when the Vatican intervened with the Sisters of Charity running the supervised injecting route, were precisely these kinds of questions. Now, that was a national first, it wasn't an international first, it was certainly first in a Catholic ministry. And there was a real reticence to accept the argument that the provision of clean needles and so on was actually going to do some of the other things that you spoke about, Adrian, which was improve the health of people. There was the assumption, I don't think it was a fair assumption at all, but the assumption made was that this was merely a way of tolerating something, keeping it at a distance, and keeping people alive, rather than actually leaning in and orienting people towards health. And I actually think that the evidence, and we're a partner of the Safe Injecting Room in Richmond, and I've been close to case studies where people who everyone thought were lost, completely lost, have started on a journey towards healing, and that is an incredibly beautiful thing. It requires a lot of pain to get there, and a lot of steps forward and a lot of steps back. But actually, and we're in a Christian context here, the accompaniment and the commitment to those people there's something sacred about that. There's something profoundly theological about that we actually hang with people, even in the middle of this complexity. And it doesn't always, can build a bridge towards. Final thing just to say on that, actually, I think that one thing that can happen in public debates around this is we operate out of the mindset of a person who hasn't experienced a substance use disorder. And the step to use a clean needle instead of a used needle for someone who's acutely in the midst of a substance use dependency is a step towards health. It might, for someone who's not an injecting drug user, might not seem like much, but someone in the grips of that stream, that's a huge pushing against the tide. Similarly, choosing to inject in a safe space, choosing to say yes to that healthcare practitioner who happens to be there and is the only person who smiles at me or knows my name. These are some of the stories that come out of North Richmond, by the way. These are the only people who know my name. The only person who's smiled at me in years. Well, I trust that person now, and I'm willing to go on a bit more of a journey with them, because they don't see the tattoo, the stigma on my face. They actually see someone worth journeying with.
That's really beautiful, Dan, and I really love hearing that, and I think that's also why we do what we do. at Uniting, and I started today saying that I think that, well, we know that this group of people are possibly the most stigmatised people in our society. Yet I've also, in my experience of all these years of working in the sector, seen them to be actually the strongest, toughest, most resilient people, I think, in community. And I think for people to be able to reach out and go into a service, whether it's the injecting room or go into a service for kind of longer term help or a rehabilitation program, takes an immense amount of courage and strength, absolute creativity. And it's really our duty to be able to walk alongside those people and help to instill that faith that they will receive the support they need along the way.
Yeah, thank you. And there's a thread in a lot of what you've both been saying that is just moving us from not just the stigma, but this thin approach of, someone's entire identity becomes their substance use, right? And actually recognising people as complex human beings that will therefore need complex and long-term, supports. But also of an element of hope, right? So I want to lean into the theological work here. As I said before, a large part of the Christian tradition has really advocated a prohibition approach. And I can understand some of the reasons for that. It's actually, I think, almost goes full circle in its best version, which is prohibition is about reducing social harms. But there's something in what you said before, Dan, about also the hope that transformation, that healing is possible. So I don't know who wants to start, but talk to us about how we think about this theologically. What is a way to put some other language around this? We'll ask the theologian.
And maybe I'll tell a story to answer that question. And actually it was a story that was told to me by Alex Whitaker when I interviewed him. So he's a non-religious man. He trained down here with the two who set up the first service for people struggling with alcohol use disorder. And then he went up to Sydney and became the first director of the alcohol and drug service there, Alex Whitaker. So he told a story about the time at which the sisters said yes to the supervised injecting room in Sydney and before the Vatican intervened. And he told a story, I think he was describing something of a liturgy where they came together and recognized the significance of saying yes. And he told this story with great emotion. He says of himself, I'm a non-religious man, but I can't help but become emotional when he tells this story. And he talked about an elderly sister of charity who stood up among this group of people, board directors, clinicians, politicians, and others who had gathered together to recognize the significance of this moment. And she picked up this kind of palm card and read it out. And she said, when we, the Sisters of Charity, confront a question like this, there are two questions that we ask to help us decide on what to do. The first question is, what would Mary Aikenhead do? Mary Aikenhead was the founder of the Sisters of Charity back in Ireland. And the second question was, what would Jesus do? And she said, and this kind of brings Alex to tears when he tells the story, when they asked themselves those questions, they could only come up with one answer, and the answer was yes. And it's tempting, at a certain level, that sounds very trite, and things like what would Jesus do are trotted out, very superficially. But when you attach it to the kinds of women these are and the kinds of work they did as a lived theological ethics, really, they knew the names of the injecting drug users in King's Cross. They loved them. They were their people. Even some people in the church said, why are you dealing with those people? And there are stories of the sisters saying, excuse me, they're our people, and we will stand with the people who we're asked to stand with. So there's a theology there of, and this, in Christian theology there's at least one of the conditions of possibility for encountering God is standing near those who suffer and continuing to stand there and asking, what can we do to respond to your need? So that is a theological ethics which answers this question in a very profound and practical way from a group of women who spend their whole lives standing in the place of need and asking, how can we respond? Alongside medical expertise, alongside the best science they had to offer. So I think that's, as a theologian, how I arrive at the conclusions. Well, I would love to arrive at the same place with the sisters, but there's a a rigour to it as well. There's a rigour to that, yes, which I think is really important.
Do you want to add anything to that, Adrian? Or is this... No,
No,
no, I just wanted to... yeah, and I think if I was to add anything to that, I mean, there is the Jesus who was with the marginalised and, with people and arguably even taking the suffering of the world into himself. And I'm not saying you didn't say this, but also in that showing people that wholeness and healing and flourishing, to use a word is possible. And so that hope that no one is beyond that, even when actually the complexities and the challenges they face seem perhaps overwhelming to those of us who have not had to face similar kind of challenges. Yeah.
And just to add one thing, I think that thinking of it in those terms gets beyond so much of the superficial politics that is endemic in an area like this. Like, no one could accuse the sisters of being kind of pro-drug use and cheering on drug dealers. I mean, all these things that tend to come out. But also nobody could suggest that they were kind of sitting at a distance progressives who just love the next greatest new idea, right? So there's actually a coherence to it precisely because of where they stood and how they responded to need.
Mm. Yeah, the Uniting Church, Adrian was a key part of this process actually at our synod a couple of years ago, did do some work to adopt a harm minimisation approach. As part of those long conversations, there were people really worried about the messaging of this approach saying it's okay to use those substances. So that had to be kind of worked through to get to those underlying and bigger issues. But I don't know, Adrian, if you want to reflect on anything you sort of learnt in working with the church in that space and what you noticed.
Yes, I think certainly that project was such an important and powerful project for us to work alongside the church on. I know Alistair McRae's here and Bromman, people who worked very closely on that. Yep. On that resolution as well to pass the health-based response to the resolution to the Uniting Church. It was that was the first synod that I had attended, and it was a terrific experience of working with, I think, around 400 people who argued very rigorously this topic, and I was actually very grateful that it didn't just pass through easily, that there was kind of 3 days of lots and lots of debate. But yes, certainly there was a whole gamut of concerns from people who were worried about if we go down this decriminalised path, what does that look like? Will all kind of will the society kind of fall apart and everybody will be using substances? And we certainly have evidence from decrim models around the world where that hasn't been the case. The world hasn't fallen apart. It's actually gone really well. And we also had kind of the other end of the spectrum. And I remember this person. It was a GP who stood up and said, "I'm actually really tired of getting to this point where I'm working with my patients who are coming in, talking about their concerns related to AOD use, and I'm actually really tired of getting to the point where we're finally getting somewhere and then they die, or they stop coming because of stigma and shame. So this is something that we need to do to change the way that we treat people in the community, is actually treating people like human beings." So for me, it was an incredibly profound experience. Yeah.
Thank you. I'm going to open it up to see if there's any audience questions in a moment, but let's just pivot to policy and I guess some of the more practical aspects of this. What would you both love to see changed, whether it's you personally or the organisations you're working with, some of the perhaps campaigns you're working on? What do you think we as a society need to change? Because it seems to me at the moment we're a little bit caught between an old prohibition model, particularly in our sort of policing and the legality questions, and a harm minimisation approach that the kind of healthcare sector is leading. So what do we need to change to really do this better?
Well, of course, I'm going to say we need to decriminalise, but it's such a simplistic thing to say we will decriminalise and the world will be different. Of course it won't be. It's this massive cultural shift over generations for change. But I think the way, if we continue to criminalise some drugs, we continue to criminalise people, and we continue this path of stigmatising and judging certain portions of our community. So if you think about, if you walk past somebody on the street, a person from a minority group, and clearly they're substance affected. We can easily judge that person as being another drug user on the street, yet a middle-aged white man could go home and knock back half a bottle of Riesling at night to kind of manage our stress and anxiety, but we don't judge that person. And so this is the difference between the legalisation and the opposite. So I think we, as a society, really need to look at how we treat people as our fellow human beings. And I do think to get there, we do need to take a depenalising or a decriminalising approach to all drugs to enable that kind of cultural shift in how we see people, because we see it as a health-based concern now. It's not a legal concern, and I think that's one of the huge barriers.
So just to be clear, can you say when you talk about decriminalising, that is quite distinct from legalising? What do you mean by that in very real terms? Someone with a very small amount of a substance for personal use?
Yes, so removing penalties for people using and we won't go into the amounts. There are standards. I mean, the ACT around 18 months ago has gone down a decriminalised approach for all substances. Portugal is another very famous, since 2000, so it's been 25 years since Portugal went down that path. So it's not removing, it's not legalising substances. I mean, some states of the US have gone down the legalisation path. That's a whole American model, which hasn't always gone well. So it's decriminalising, but not actually legalising the substances.
And just another follow-up, am I right in thinking that at the moment Victorian police actually have a bit of discretion, and maybe it's only for certain substances, that can lead to the kind of stigmatising you're talking about in terms of, depending on the profile of the person who might be drug affected or have a small amount of a substance on them, police can choose to kind of prosecute and treat that as a criminal matter or let someone effectively off? Is that what's happening right now?
In most jurisdictions around Australia, we have various versions of this. I mean, a drug diversion program or a drug education program is one of those examples. So it may be a diversion into some form of education program. So yes, in Victoria, but also around Australia, we have a range of different models. Yeah.
But the possibility of other stereotypes coming into that in terms of the way that the Anglo private school kid gets treated versus the poor Aboriginal kid, to choose some stark examples, would probably be quite different, I'm assuming.
Yes.
In our system. Dan, do you want to add to this, or more generally what policy shifts you'd like to see?
I leave the policy to the policy experts, but the vision, going right back to the beginning, the way of seeing, I think if that young man's story I told earlier, that sentence story, if that could be different, he didn't end up behind bars. Many people do, and that's not a great place to get healthy either. That often will exacerbate things even further. So my question is really, what could have happened right at the beginning there that would have led to a different outcome? What leads to a health approach? What leads to a person finding better ways to deal with their anxiety? And, all of the different things that could have happened in that young person's story. And, I mean, this isn't always the way I do ethics, but that could easily have been me. It could easily have been one of my friends, it's just, this kind of accident of circumstance that for some people it ends up. And it doesn't have to be that way. We can build a response to this that's built on justice, if you want to use secular terms, or love, if you want to use theological terms, loving concern for one another.
I'd love to read a quote from a consumer of ours that talks, I think, really closely to this, particularly in relation to stigma. So the consumer, I'll call him Toby, says, "It was the stigma, the way people saw me as some kind of criminal because I was really just trying to survive the best way I knew how, just trying to numb pain. It really affected my self-esteem, and if I was trying to go for work or anything like that, most places wanted police checks. Even trying to do voluntary work was kind of difficult because people wanted police checks. I had issues also with trying to volunteer at my church in the community centre because they wanted a police check. I was really hesitant and didn't want anyone to know about my substance use. There's been things I've wanted to do because of my history, I didn't pursue them. If I hadn't ever been charged by police for possession, it would have helped me get employment without having to worry about sharing my story. Now that I do have a spent conviction, it is a really good feeling. It's freeing to know that if I want to do anything and they ask for a police check, it's not going to come back with anything. It was a good feeling. I was over the moon. I think we should be focusing on how we can help people rather than ruining their future life by giving them a criminal record."
Thank you. I'm going to open it up now to you if anyone has a question.
I was just hoping to get some reflections from both of you about harm minimisation when it comes to other people, because you spoke a lot about harm minimisation for the individual who's using. I come from a background of family services, and looking at those, a lot of focus on harm minimisation on children, on families, on social connections, friends, community groups, churches.
I guess harm minimisation, if I'm understanding your question right, harm minimisation is or should be designed with a focus on the broader community, on the families, on the extended family or the broader communities generally. And I think the seatbelt example is actually a really terrific example of harm minimisation that saves not only the person who's driving the vehicle, but the people travelling in the car and other road users or pedestrians as well. So harm minimisation is never designed focusing only on the individual, but within the system that it's there to support. Does that kind of answer your question? Yeah.
And I think, thinking ethically, the ethics is never just about the one person. So it may be that we stand first with the person who's suffering most, but we can recognise that what's going on for that person might spill out in behaviours that are intrinsically dangerous for other people. And we need to find ways of protecting other people from those behaviours without at the same time creating more problems. And that sounds like the kind of work you're involved in, is all of that creative and courageous work that is needed to be able to address those problems without, just ostracizing and pushing one element away. I think that there's something we didn't discuss really, but actually is relevant to this question as well, which is the place that people with lived experience or living experience can play in all of these different areas, which is, a colleague of mine said this to me this morning actually, the enormously courageous act of choosing to join an organisation, for example, like a hospital or the organisation you work in, Adrian, and saying, I am a person with lived or living experience, is in a sense amplifying the tattoo, amplifying the brand. What an enormously courageous thing to do, but we've seen, and there's a lot of evidence to show that the solidarity created by someone who is new to seeking out help or arrives in an emergency department or whatever, can actually then create a platform from which more generative responses can come. And I would assume that that's very similar in your space as well.
I wanted to pick up the question of who pays. All of the things you said resonate with everybody here, I'm sure. The question is, who funds it? We're talking about the circular economy now. Is there a case for those who produce these materials, particularly alcohol, providing a much better contribution to the restoration of people?
I'm going to give it a bit of a stab. So we do know, and this is really quite old data, so I'm going to say that first up. We know that wherever we... Okay, so I'm going to jump aside and I'll come back. So if we're talking about going down a decrim path, you can't just do decrim in isolation. You need to put in additional services. You need to provide more support to people who are seeking support for their own or their family members' substance use. Of course, there's a cost involved in there in increasing services, and who pays for that. We do know that, and this is the very old data, and there may be somebody here who knows this better than I do, but there is something around a 7-fold decrease in costs from criminalising somebody to providing treatment. So there's a significant reduction in cost to society, in financial cost to society, in providing AOD treatment to somebody in their life than there is in auguring that money into the criminal justice system. That might start to answer your question. Do you want to add anything?
Oh, only that, so yes, I think that a burden should be carried by those who create the problem in terms of solving the problem, although in a very precise way, because there's also a risk that we as it were, can outsource our conscience through paying for treatment programs. Does that make sense? So I'm a big... gambling is a good example of this. Like, gambling companies will often do a lot of philanthropic activity which enables them to apply for more licenses to run more pokie machines which profit off people's misery. And I actually don't think that circularity works. There has to be a deeper commitment to transformational change so it doesn't become a case in which something that's creating the problem can pay off its conscience and pay. Good if it pays for some work. You know, the sisters were very famous for going around the pubs in Fitzroy and in Darlinghurst with a tin and saying, come on you men, give us some money so we can run the hospital down there because you'll probably end up there later. But so there is a sense in which, yes, that creates a communal sense of responsibility, but it could also become a pernicious thing where we feel like we don't have to actually take responsibility for the deeper issues because we've paid for the treatment service down the street.
Yeah, I feel like we need an economist here, but it seems to me we also spend ridiculous amounts of money, as you've pointed to, not just in the criminal justice system, but the policing that goes on around that. It is one of the possible arguments for legalisation more fully, although we don't have to go there. You know, the economics gets complicated, but the user pays stuff, and I'm not sure what was perhaps behind your question, Ken, but there is a sense, again, if we're looking at this holistically, and that a lot of drug use is that, you know, coping with life, that, you know, often the self-medicating, or it starts in that kind of way, then it is a we are all responsible, because we've created a society that doesn't have the mental health services, where people are lonely, and so on and so on. So, yeah, there's a communal responsibility to that. Are there other questions? We probably have time for one more.
My last one follows well from Ken's in that it appears to me like public policy is having much less connection to real data from real life and much more knee-jerk getting into power type connections. How do we cope with that?
I think we cope by continuing to push on and do the right thing by the people in our community who we want to continue to work to improve their well-being, and we use our data and our terrific outcomes that we have from our treatment services to continue to advocate up for greater change from government and for ongoing or broader funding to continue to fund our services. And we focus a lot on advocacy. It's a really important part of what we do.
The state of politics is not great anywhere at the moment, is it? And that's kind of central to your question. A lateral story came to mind. It's very brief. A colleague of mine who I used to work with, brother used to be a bishop, a Catholic bishop. And when he became a bishop, somebody said to him, congratulations, you're now a bishop. That means two things. Number one, you'll never have to pay for a meal again. And number two, no one will ever tell you the truth again. And there's something about the way hierarchies work, I think it's true in political systems too, that it's hard to filter through the truth. Going back to that quote from Cornel West, the condition of truth is to allow suffering to speak. And I think the best examples of advocacy I've seen and policy change I've seen have actually been through bringing decision makers close to where the suffering is. And that's decision makers at all different levels. This is in governance, in organisations, this is in politics, this is in church and so on. When we come close to the suffering, our epistemology changes. The way we see the world changes precisely because of where we've stood and the experiences we've had there. And unless we're really kind of callous, it talks to our conscience and our conscience develops. So maybe it's naive of me to say this, but a hope is actually that in getting beyond so much of the noise that infiltrates politics everywhere at the moment, there's a proximity to suffering and need and what good looks like that can actually change hearts, change minds so that, you know, good can be achieved.
I want to thank you both for sharing from your experience, your knowledge in this space, for opening our eyes to see beyond a substance or a thin reading of a person to the fullness of the complexity and people's lives here. So thank you both for giving your time, and I know both of your organisations are doing such important work in this area, and if people want to know more, I'm sure there's things you can find on websites and reports to read and so on. But can we thank Dan Fleming and Adrian Webber, please? Next month, it's on the screen, we're pivoting to talking about the ethics of technology. We have a couple of American ethicists and a local theologian coming to help us do that. And in August, we've just confirmed that Jenny Macklin will come and talk about her new book, which is about how you make good public policy. We're going to be moving to the business hub next door. It'll be a bit cosier and warmer. So you'll be able to come and find us there, but thanks all for coming. And if you want to know more about the work we're doing, you can find us at thewesleycentre.com. Thanks.